Keto San Antonio, it's Anna, and happy Easter morning to you all. We are really blessed this morning. We're going to get to talk with Dr. Michael Garrett out of Austin, Texas, and he's going to be sharing with us a little information about insulin and hyperinsulinemia. So let's give folks a moment to join us. Hey, Robin, glad to have you. And there's Dr. Garrett. Hey, Michael. Let's try this again. Hey, hopefully this will work this time. Hey, Sylvia, good morning, and Lindy, glad to see you guys. There we go, I can already
All right,
hear you.
you can hear me? Great.
Yay, awesome. Morning, guys. Really excited to have you talking with us this morning, Michael. Thanks so much for taking time out of your Easter, and we're excited to hear about what you have to share in regards to insulin and hyperinsulinemia.
Yeah, thanks for having me, and happy Easter. Are you able to hear me okay? I'm not sure if I've got the mic in
Yes,
a good spot.
you
Okay,
sound great.
great.
Thanks.
All right, great. Yeah, happy Easter, everyone.
Yeah, and it looks like we've got Sheila joining us and Colleen. Let's give just a couple of moments for folks to kind of jump on. Hope you had a good week. How was your week?
It was really good. It was really good. A tiring week. I added a second doctor to my practice, so it was just a busy week, a lot of administrative things, but we're rested up this weekend.
Good, good.
How about yours?
Pretty busy, but very awesome. We had our first Keto San Antonio singles group yesterday, which was kind of an attempt to reach out to our folks that are single and provide a kid-friendly activity too, so that single moms and single dads could kind of bond and make some friendships. So that went really well. And
I saw some pictures on Facebook from that. Yeah.
Yeah, folks had a lot of fun, so it was good. But we've got a good little group here. Let's go ahead and get started, Dr. Garrett. If you could kind of start off maybe with talking to us a little bit about insulin, and we'll go from there.
Sure. So I think it's helpful to just understand the basic, way that insulin works in your body and the basic things that it does. I think most people understand that insulin is a hormone that helps regulate our blood glucose. That's kind of the primary function of insulin that most people already recognize. They either know somebody, a family member that has diabetes or something. They know that this insulin has to do with managing blood glucose, and it does. That's a crucial role of insulin in our body, is to keep our blood sugar in a narrow, normal range. So insulin is necessary and good. We have to have insulin. And it also has other functions. Insulin works as a hormone, not just for regulating blood glucose, keeping it in that range, but for getting glucose into cells for use. So it gets glucose into our muscle cells to be used by the muscles, or it gets glucose into the muscle cells to be stored as glycogen, like stored energy to use later. It gets glucose into liver cells, into adipose cells. And the adipose cell part is a key kind of thing to understand when we get to hyperinsulinemia. When people's insulin levels are chronically too high, one of insulin's other key functions is energy storage. So it gets glucose into these cells to store, but your liver and your muscle cells can only handle so much glucose in the form of making glycogen. And then after that, it has to store it somewhere else. And so another thing I tell people frequently in the office is another key feature of insulin is it's a fat storage hormone. It's an energy storage or fat storage hormone. And understanding that is helpful for understanding why things like a ketogenic diet or intermittent fasting or a very low carb diet, there's a variety of different ways of eating to help try to manage that. But we're often targeting, trying to lower the insulin levels because that is a fat storage hormone. That's something that people don't always recognize.
Earlier you mentioned that insulin is also affects adipose tissue. For those of our audience that are new to some of the terms, can you explain what you mean by the adipose tissue?
Oh, so adipose tissue, just a fancy medical word for fat tissue or fat cells. And, we have fat cells, distributed throughout the body under the skin, and then visceral fat, which is the fat kind of in the abdominal cavity or inside the abdomen, and that can be in the organs. And that fat's more metabolically harmful if you build up a lot of fat in those places. If you build up fat, for instance, in your liver or your pancreas, it does damage those organs and affects how they function. But the bottom line is adipose just means fat. So adipose tissue or adipose cells are fat cells.
Great. Thanks for clarifying that. Well, for those of us that are on the ketogenic diet, what are some ways that you could recommend that we help control our insulin levels? Granted, eating ketogenically is a big effort towards that, but do you have any suggestions?
So understanding what things promote insulin release help some, just so carbohydrates are going to promote insulin release. Eating carbohydrates in your diet are going to promote insulin release more than other foods. Protein promotes some insulin release, but I wouldn't limit protein. I mean, I don't want people to limit protein in an effort to get their insulin levels down. And fat really has minimal effect on dietary intake of fat. Has minimal effect on insulin. So knowing those helps. And then among the carbohydrates, the more processed or refined or simple the carbohydrates are, like sugar and flour, those just make a quicker response in the blood glucose going up, and then a quicker or a larger response from your body making insulin to try to keep that down. So if you're going to have carbs, you want to have carbs that are with some starch, or with some fiber, that are going to slow the release. You want lower glycemic index carbs. And you can look there are little resources online where you can look that kind of thing up. But so, the one other thing just to say as a practical point is, if you're going to have carbs with a meal, if you have your protein and your fat first and then your carbs, it's going to be better metabolically for you than having the carbs right up front, where they'll get absorbed more quickly. If you have the protein and fat, that also delays, the absorption of those carbohydrates if you have the protein and the fat first. So you get less of an insulin response.
Really good good point. Last week when we visited, we talked a little bit about some of our experiments that we're going to be doing with blood glucose. And I'd asked you a little bit about the tanking of blood glucose and what that can signal to folks if they're testing their blood glucose. For instance, we talked about artificial sweeteners, such as sucralose, like Splenda, and the effects on insulin independent of like a blood glucose spike. Could you talk a little bit about that? About we talked a little bit about how that can possibly be an indicator of insulin.
Insulin resistance, or insulin secretion in response to that. Yes. So a couple of things to say about that. I mean, one that's related, but it's not exactly your question, but is this idea of hypoglycemia, hypo meaning low, not hyper, but hypo, low blood sugar. Some people have been diagnosed with hypoglycemia. This is not patients that are diabetic or taking insulin or other medicines to lower their blood sugar, but they get it in response to food sometimes. And that is an indication that their insulin levels, typically, almost always, that's an indication that their insulin levels are chronically too high. And then when they have some carbohydrates, they get a response and their blood glucose comes down, but it comes down too much. So that kind of reactive hypoglycemia after eating is often an instance of hyperinsulinemia, or too much insulin in the blood chronically. And the same kind of thing can happen with the artificial sweeteners. That goes to one of the things that we talked about. Sometimes these things may affect different people differently. So some people will report, well, I do fine with that and it doesn't cause me a problem. Even if they're checking their blood glucose, it doesn't tank after that. Well, that may be an indication that that person is more metabolically healthy or doesn't have hyperinsulinemia. It could be that that's why that is. But for somebody that does have that, drop like that, to me, it strongly suggests that their insulin level is going up just from that big fancy medical term for it is cephalic phase insulin response. But the brain detects something sweet and just from an evolutionary perspective, it says, oh, we're getting ready to get a load of glucose. Let's go ahead and get the insulin started to try to blunt that. And then the sugar never comes because it's an artificial sweetener that doesn't have calories, right? So the insulin then will go high. Maybe it's already somewhat high when you have it, but then it goes even higher, and then the glucose level drops. And sometimes it really drops low, like below 70 is an abnormal glucose level for most patients, or most people. I keep wanting to call people patients.
It's okay. You're great. What are some maybe physical symptoms or signals that folks like myself could look for that might indicate some level of hypoinsulinemia?
So I think you mean hyperinsulinemia, like their insulin levels are too high. What might be signs of that? Yep. So so I'll give you just a few that are maybe something that they might see themselves. But then also I want to tie that into all the diseases that hyperinsulinemia is highly associated with or contributes to. And they're all the common chronic diseases that I see every day in the office and that people are familiar with. So there's a few physical things that people might see with hyperinsulinemia. One of them is getting episodes of hypoglycemia. They may get weak or shaky or nauseated or jittery or sometimes even a little clammy and maybe craving carbs an hour or two after having a sugary or a sweet meal. Those are hypoglycemia symptoms. Other things that are kind of, and that's on a single basis, like one time when you eat something, but other things that are suggestive of or make me think about chronic hyperinsulinemia is if people get skin tags. Now, skin tags, like these little things that look like they often happen around the neck or the underarm, places where there's sometimes a little bit of friction, but they're much more common in people who have chronically high insulin levels and even diabetics. So they're very soft, fleshy. They're not like a wart where they're firm. They're very soft. They tend to have like a little attachment and then like a little neck and then a loose part that moves. Those are kind of a warning to me when I see patients or people having those, say, might have chronic hyperinsulinemia. Not always, but it's definitely one physical sign. Another one is, I don't know if this has a lay term. It's got a big fancy medical term called acanthosis or acanthosis nigricans. People get like a dark kind of brown or black, almost velvety areas on their skin in the underarms or on the neck are common places to see that. And that's commonly associated as well with hyperinsulinemia and also with type 2 diabetes. Doesn't mean the person has type 2 diabetes, but it always means that they need to be checked for that. So those are kind of some physical things that you might see. Also, waist circumference is sort of an indicator or marker for that. And women whose waist, this is, I should clarify when I'm talking about waist measurement, we're not talking about just what you put your pants, because that often is down just above the hips and that number will be smaller, but we're looking for that abdominal circumference. So the area around your belly button within an inch or two of that. So it's usually bigger than the, where people wear their pants. But if women's waist measurement there is 35 inches or higher, they're more likely to have insulin resistance or hyperinsulinemia. And men 40 inches or higher is more likely to have that. And then if I can just tie that question of what are some things that might give you an indication you have hyperinsulinemia, the other thing is any of a certain group of disease processes, if anybody's been diagnosed with any of these things, you may also have been recognized by the doctor to have insulin resistance or hyperinsulinemia or be told you're pre-diabetic, but they don't always tell you that, or they don't always recognize the connection. So common other things that go along with it is high blood pressure, chronically elevated insulin levels through what they do in the kidney and retaining sodium and inflammation. They cause high blood pressure. And I believe actually most high blood pressure I see is related to chronic hyperinsulinemia or insulin resistance. But so high blood pressure, a lot of cholesterol problems actually, and we're going to talk about that I think next week, but a lot of cholesterol problems are actually driven by chronic hyperinsulinemia. So high triglycerides, which is one of the bad cholesterols, low HDL, which is the good cholesterol, those abnormalities are often caused by insulin resistance or hyperinsulinemia. A bunch of other kind of common health conditions, PCOS, which a lot of women have, erectile dysfunction, which men suffer from, those are often related to hyperinsulinemia or, insulin resistance. I had a list of some other ones that I was just going to mention. Oh, fatty liver disease, NASH or NAFLD are the kind of acronyms, but basically fatty liver disease. And sometimes both symptomatic and then later a diagnosis can be brain fog. Like some people, high insulin levels will get brain fog, even aside from when they have hypoglycemia, which definitely makes your brain feel like it's not functioning right when your blood glucose is low. But brain fog is a common symptom of hyperinsulinemia. And then later, I think it contributes to, dementia, which I think is increasingly being recognized as type 3 diabetes. It's hyperinsulinemia chronically for years, and it's insulin resistance affecting the brain. So that's a long list of things, but those all are sort of, so if you've been diagnosed with any of those at the doctor, you should address, well, do I have high insulin levels? Do I have hyperinsulinemia? And probably be tested for that. That's another thing I think we ought to talk about at some point, either now or later, is that how to test for it.
Sure. Why don't you talk a little bit of how we can have that tested so that we can start addressing it? Folks like myself, patients, clients, folks.
Sure. So for your what do you call them? Data junkies and the people that are already testing at home. I mean, they can have indications of that just based on what their blood sugar is doing. If they're getting blood sugars that are significantly high, 160, 180, that it's not unlikely, but likely that they have some hyperinsulinemia. But home testing, and you can also check for ketones. When you're in ketosis, usually your insulin levels are low. Those are kind of both proxies, but they're not a direct test. And there's no home test for insulin. And I don't know how long it'll be before that happens. But at the doctor, when you go to get labs, often they'll just check this A1C, or hemoglobin A1C, it's called, where it's basically kind of a measure of roughly what's your blood glucose been doing the last 90 days or 3 months. That test is okay, it has utility, but it's not good enough for detecting hyperinsulinemia, and it often will not show it for a long time. I had a patient last week who had a 2-hour glucose tolerance test and was totally type 2 diabetic, not previously diagnosed, and her A1C test was just at the borderline of abnormal. So basically the tests that are most helpful for diagnosing hyperinsulinemia is a fasting insulin. So when you go to get your labs, be fasting and have them get a fasting insulin level. And doctors don't routinely order that, but it can be very helpful. So a fasting insulin level. And then really, I still think that the glucose tolerance test, where, you drink a sugary beverage, 75 grams of glucose, and then check your levels at 1 and 2 hours. Those are really helpful. And I think the best test, as Dr. Joseph Kraft kind of developed this insulin assay, where you're actually checking the insulin levels as well during each of those blood draws during the glucose tolerance test. That's the best. That's really the best test. But the quickest, if people often don't want to sit in the lab for 2 hours, fasting insulin, fasting glucose are fine.
Yeah, folks like myself, whenever I have that suggested, the actual glucose test, it kind of scares me. Is that something I shouldn't be afraid to do? I mean, since I've been in ketosis for so long, I'm kind of scares me to.
Yeah, I understand that too. I understand that too, because 75 grams of glucose is going to kick you out of ketosis. It is. I don't think it's something where people should be going around drinking 75 grams of glucose all the time, but this is for a very specific purpose, for what I consider a very good cause, which is finding out definitively whether you have hyperinsulinemia, insulin resistance, and even type 2 diabetes. Again, if you don't want to do that, you should at minimum be getting a fasting glucose and a fasting insulin, so that you can calculate this HOMA-IR, this score of insulin resistance, with those two numbers. That would be the minimum. And there are times where I don't have a patient do a 2-hour glucose tolerance test, even when I would kind of like to, because of what they're doing, metabolically and not wanting to come out of ketosis. But 75 grams of glucose one time is not going to be metabolic havoc that's going to cause a long-term problem. I mean, you may feel lousy with it. And it may take you 12 or 24, or depending on where you are metabolically, it may take you a little while to get, back out of ketosis. Now you can, after the test is over, you can also go walk afterwards. I mean, I tell people there are strategies for how to deal with that. They don't want you to exercise during the 2-hour glucose tolerance test, because they want to get an accurate reading of what's happening with your glucose. And if you run out and get on a treadmill or go walk for 30 minutes while you're waiting to get the next blood draw, that's going to use a lot of that glucose. So you don't want to do that, but right afterwards you can. Once you finish the test, you know,
Okay.
you can do some exercise or activity, or you can have a meal with protein.
Mm-hmm. Okay. Great. Well, go ahead and I forgot what it was you were going to talk about, but I just wanted to ask that about the glucose test.
So I know I had wanted to talk about just all those diseases that we see, you know, that commonly are caused by hyperinsulinemia or insulin resistance, or are, to me, triggers to say, is insulin resistance the root cause of this? So if I see in a person's medical history, or I diagnose myself, any of those things that I mentioned, which is your high blood pressure, cholesterol problems, any heart disease, any vascular disease, because the vast majority of vascular disease is from hyperinsulinemia and insulin resistance. Even if they're not diagnosed diabetic, it's usually the root cause of most. When you're talking about people who have had heart attacks or strokes or blockages or had to have a stent in their heart or an angioplasty, those people, most of them have hyperinsulinemia.
Yeah, that's such an important point. So often folks blame fat consumption on heart disease when really it's sugar and
yeah,
insulin
it's sugar and high insulin, and then that causes an inflammatory process. I still don't fully understand whether hyperinsulinemia and insulin resistance just cause inflammation, or if inflammation from some other source is the trigger for them. Sometimes I think sometimes that may be the case. But either way, I mean, yeah, the very first thing to address if you've had any vascular disease is insulin resistance. It's unusual in my experience to see a person that has any vascular disease that does not have insulin resistance as either the main root cause or one of the, you know, top two causes for that.
Good point.
So I'm going to try to look on my phone where I'm doing the video. I can't see any comments, but I'm going to try and just take a look and see if there's any comments or if anybody's got questions.
One of the questions, very important question posed by Lindy was, are you on Instagram? Because we'd love to follow you.
So I don't think I'm on Instagram. I may have an account. I definitely don't use it. I'll have to check. I feel like I made an account years ago and have never used it. So I'll have to see, but I don't think I am. I'm certainly not active on Instagram. I don't post things on Instagram, that sort of thing at this point. I mean, I'm open to considering that again, but I never really, I'm comfortable with Facebook. I understand it. It's easy. And Instagram, I don't know. I thought of Instagram mostly for posting pictures of stuff, food or something like that. I don't know if there's other info.
Right. I've posted about us doing the Facebook Lives on there, but Lindy was asking that, so I thought I'd ask. Guys, do you guys, Keto San Antonio, do you have any questions of Dr. Garrett? We'd love to address those. Let me also look back and see if there are any that I have not seen. Melissa says, hi, Dr. Garrett. Great to see you. Thanks for sharing your knowledge on insulin, low carb, keto, and more.
Hi, Melissa. That's actually Dr. Melissa Launder. She's a direct primary care doctor in Florida.
Awesome.
So, yeah.
Thanks for tuning in. Let's see. Okay. Lindy has a question. She says, great info. Another important question. Are you taking any new patients? Dr. G?
That's a good question. I've really been waitlisted. I've been full for quite some time now and putting people on a wait list. And I just had a new doctor join my practice this week, Dr. Linebarger. She'll be accepting new patients starting, this coming week. She'll be seeing patients starting Tuesday, and she's taking new patients, and she's keto friendly. She's done keto. I don't know if she's doing it right now. She's done keto in the past, and she's definitely keto friendly and keto knowledgeable. So I'm not at the moment taking new patients, but there is someone, available in my clinic for the people in the Austin area or that are willing to travel.
Perfect. And for those of you watching, in the information of this, or the information title for this live, I have put contact information for Dr. Garrett in his office and his email. So you're welcome to contact him through that. Any other questions, guys? Well, next weekend, next Sunday at 10:30, we're going to meet up again here on Facebook. And if you'll share the topic we're going to talk about.
Yeah, I think we're going to talk about cholesterol. That's a
Awesome.
really, really broad topic, but cholesterol as it relates to keto diet, it's a common concern that I get sometimes, when I recommend, say, low carb or keto diet, I commonly get that concern. What about my cholesterol? Oh, the cholesterol goes up. Uh-oh.
Right.
Yeah, so that's a great, I think, subject for conversation.
Great. Amber Leon just posted a question. She said, thoughts on eating carnivore.
Hi, Amber. So yeah, I eat carnivore. That's what I've been doing for about 9 months with really minimal exceptions. And I think it is a powerful way of addressing, to tie it into the topic from today, hyperinsulinemia, chronic hyperinsulinemia or insulin resistance, metabolic syndrome. It is about as effective as anything else I've seen, which, including keto and other low carb options. So yeah, I have a lot of thoughts on that. But it's a pretty, that's pretty radical. So I try to, even when I do have people consider doing a carnivore diet, temporarily or long-term, it's best for them to come from a place of keto to begin with. It's a lot easier to transition if they're doing keto to go to carnivore versus just starting from scratch, standard American diet to carnivore. That transition can be a lot harder. So yeah, maybe that's one we can talk about another time too, because it's a whole subject in its own.
It is. And when I've gone carnivore, this is just a little aside. I actually had to try it like 4 times before, because I wasn't feeling real good starting off. And I finally figured out it was my electrolytes. I had to bump up my electrolytes, or I have to when I really am pushing the carnivore. But again, our individuality, not everybody has to do that. My husband has no problem, but I have to really bump up my sodium and my magnesium when I'm doing it.
Yeah, that's interesting. Anecdotally, I mean, everything about the carnivore diet is anecdotal, right? We don't have great, scientific studies or randomized controlled trials of this, but anecdotally, I've noticed that it seems easier for men to transition into that diet than women for whatever reason. Doesn't mean women can't do it. There are women that have been doing it for 10 or more years, very successfully, getting great results, healthy. However, yeah, I've definitely seen that it seems easier for men to transition to it for some reason. That may be hormonal.
It's pretty interesting, but once I did and I figured out the electrolyte little key, it's great. I'm getting ready after Easter, and I'm going to go back a little more strict carnivore. Let me go. I've got another question up here from Sunny Parker. She says, if we test our glucose readings before and after using any particular sweetener, and we don't have a significant drop in glucose reading, can you make the assumption that you are not having a major insulin response? That's a good question, Sunny.
Great question. Hi, Sunny. I remember Sunny's story from when Dr. Berry and Nisha and Ask Nurse Cindy were there. That was really inspiring. That was really wonderful. So yes. I think that's the same Sunny, right? Sunny Parker. Yeah. So that's a great question. And I think that's right, Sunny. I think that's right. If you were having a significant insulin response, I would expect to see some effect on the glucose. So I think that that's a reasonable inference. The only way to know it for sure really would be to, which is not very practical, would be to do the sweetener at a time when you were going to a lab and getting a lab drawn insulin level. But for sure, a proxy for that at home would be looking at your glucose before and afterwards and see what it does. I think that's a good thought process.
Great. Okay, Dr. Barrett, thanks again for taking time out of your Sunday and on Easter Sunday, no less, to help us out, help educate us. And thanks for putting up with all these environmental sounds, but inside it's a little louder. My husband's helping get ready for family that's coming over. So anyway, have a great, happy Easter. Enjoy your family. And we will see you here next Sunday, 10:30 a.m. And our Keto San Antonio folks, be here, be square.
Thanks, Anna. You have a great Easter too. Nice talking to you. Take care.
Take care. Bye-bye.